new technology, new procedures, how well it is received by the patients.
Patient perspective, there are only two things. One are the outcomes, two will be the cost.
So every technology has its bit of challenges.
So it's like you have a new camera which comes, then there are certain tools which you need to come out of your comfort zone. So it's kind of relearning everything.
So unlearn something and learn something.
Yes, the principles will be the same.
Hello and welcome to the News Minute. This is Real Talk powered by the Apollo Hospitals, Chennai. And today I'm joined by Dr. Ajeet Arulkumar, who is an interventional cardiologist at the Apollo Hospitals. And I'm going to talk to him about new technology in interventional cardiology. Doctors, thank you so much for talking to us. Just to set the record, people may not be familiar with the topic that we are talking about. What exactly does interventional cardiology involve? And how different it is from the traditional cardiac surgeries.
So interventional cardiologist, the traditional cardiologist opens the chest, whereas the interventional cardiologist is the person who goes inside the heart but without a surgery. So we don't put a knife. So in a typical interventional cardiologist armatorium, there is no knife, but we do puncture the arteries and then go inside and check what is happening. To be put very simply, we are like plumbers. So we go do the plumbing work of the heart, but without opening the heart per se.
So what is the one piece of technology that has changed the way in which the surgeries are done or the procedures are done?
I think over the past several years, maybe last 30, 40 years, there's been a gradual shift. So what was initially being done as open heart surgery, where you had to have your surgery being done by an open heart specialist. Now we are doing more and more procedures less invasively. So for the patient's benefit, what happens is he comes in the morning and can leave in the evening, and he can drive in and he can drive out. And the other thing is, what we were doing as doing procedures like angiogram is now going to the radiology. So in a way, patient is getting things done much faster, much quicker and much more efficiently.
And this is minimally invasive.
Minimally invasive is a very kind of transient term, but from an interventional cardiologist, it means no knives at all. So we don't use knives at all. We only put a puncture, just like you getting an IV drip. So our procedures will require only such a small hole, and through that we can do the procedures in the heart.
So this is all done in the cath lab. It's not.
Yes, it is not an operating theater per se, but it would essentially be the same. The difference is the cath lab, how we can image the heart is by using an X-ray tube. So it does require radiation.
And can you tell us about one tool or device that you have started using and has made your job more precise?
Yes.
Or something like that.
I think over the years, what we have started doing differently is we have started using intravascular imaging technologies. About 20-25 years back, when we started, we could only use the X-ray to find out what is happening inside. Beyond the X-ray, there was nothing really which we could see. Today, what has happened is we have miniaturized cameras, we have miniaturized ultrasound, we have sound waves, light waves, which can go and image the heart. So not only can we go and do the procedures, we can also check if we have done a good job. Angioplasty, which was done 20-25 years back, is very different from what is being done now. And the outcomes are also much, much better. In a way, there was a time when people used to say, your stent is not so good. Probably bypass is better. I know people whose stent has come back. But today that number is very less. About 95% of our stents will do extremely well. And in many cases, it is, kind of provides a lifetime management for the patient.
So how are these technologies assisting you in making decisions faster? Because
I think it is more like we are seeing earlier only a still image when compared to a video image. We have a lot more information, a lot more clarity in what we are doing. This confidence gives us, more ways by which we can, our margins of error are less, our room for improvement is more. In the end result.
Also, are these technologies accessible everywhere or only big cities have it?
I think when it comes newly in the market, only the big cities do have it. Bigger hospitals have it. And then what happens is over time, as newer technology comes, the older technology gets cheaper and gets more widely acceptable. So then it kind of trickles down to the other tertiary places. Yeah.
So every technology has its bit of challenges.
Yes, yeah.
What are the challenges that you face in adopting or implementing these technologies for your procedures?
Yeah, I think one which we discussed is cost. That is the from the patient's perspective. And for us as clinicians, what happens is with everything there is a learning curve. So it's like a you have a new camera which comes, then there are certain tools which you need to come out of your comfort zone. So it's kind of relearning everything. You
So
just
unlearn something and learn something
Yes, the
new.
principles will be the same. There is going to be a learning curve whenever a new technology comes in. So that's always there. And we do have to kind of partner with the industry, with other people who do teach us. But that happens with every technology. You can't say, okay, I'm the cardiologist, I've been doing it for 20 years. But that doesn't mean like you will be familiar with the new technology. So you have to put yourself back as a student and relearn it again.
How do you see this role of AI technology or data analytics playing a big role in preventing heart diseases, or rather than treating? We are talking about treating. Like prevention is something that people.
Yeah, I think it has got a huge role because ultimately in cardiology, at least, we are using probabilities. If you go to a cardiologist, the first question he'll ask you is like, do you have diabetes? Are your parents having heart disease? Essentially, what we are doing, juggling in our mind, is kind of getting probabilities and seeing what is the risk that you have, which an AI would do much better and more efficiently. So there is a big role. AI can predict, is already predicting outcomes much better than a human doctor can do, and definitely that is the way forward.
So now there is this thing that if you feel little discomfort, if your ECG is clear, if your echo is clear, then everything is set. Is that?
No, that's a huge myth, and I'm happy you brought it out.
Yeah.
Because an ECG and echo only show what is happening to the heart at that time. In other words, like it's like a car. If you start a car and it's at idle, and if it is switching on well, it doesn't mean that the car is doing well. You have to really accelerate the car and see what happens to know problems at the start. So I'm a great fan of treadmill test. And the biggest myth is patients feel that ECG echo normal means heart is take care. So let's stop with that. That's a myth. It doesn't stop there, and many times you do have to kind of stress the heart and then check what happens to the heart while it's stressed.
If you could fast forward for 10 years, what would be the scenario of these procedures, how these procedures are conducted? What is the one bit of technology that you wanted to see in your area of expertise?
I think one of the things which we find is the unpredictability of the response. While the technology is there, we are not still able to kind of millimeter precisely go and do it. And second thing is, we don't have a one size fits all. Now there is, of course, 3D reconstructions. There are labs in Chennai itself which kind of give you a model of the heart. For the surgeon, he can look at the heart and see how the arteries are going to be. It will be good if we already know what is happening inside before we go to a patient. It works well when we do a non-emergency procedure. Sometimes things will be very chaotic. It will be good if we could have a method by which we already know what to expect even before we go to that point.
So this is my favorite part of these interviews, because this is a section where we ask you questions about the common myths that are there in public domain. Now Google is a doctor, ChatGPT, you have Gemini, you have a lot of AIs that is giving you medical advice.
Yes.
But the common thing that is there on internet is, there are these myths. AI can diagnose heart blockages better than a cardiologist. Is that true?
I would say it will be better at predicting the probability, but on an individual person, it may not be better because it may not have the right tools. So you do need a cardiologist on an individual level, but on a holistic level, giving like, okay, you're a diabetic, hypertensive, AI will be slightly is better at predicting.
What exactly will AI do? Like it will tell you.
Yes,
something.
AI will be like Google Maps. It can kind of predict which way to go, but which will work for majority of the people, but it may not know exactly in the right sense if there is an accident which happens then and there.
This is like really, my favorite question. Like AI can diagnose heart blockages. Like it's sure
it can,
that
it can't, but it can predict the probability, which is what we are also doing in our minds. We are actually putting small risk factors together and trying to get the predictive power of what happens.
The next one is 3D imaging eliminates the need of conventional angiography.
That is totally wrong. While 3D imaging helps to identify or to give us a 3D perspective, it does not eliminate the angiogram. So, doing a CT coronary angiogram gives us a 3D image of the heart, but it doesn't give us exactly what is happening inside the coronary
So
arteries.
it will give you a general visualization
yes,
of what
yes.
exactly
Yeah.
it looks like.
Yes.
But it's not a replacement.
It is not a replacement for a conventional angiogram.
And my next question is, laser angioplast is the safest and most advanced option for all patients.
No, it has got its own special role. It is a very good option when there is calcific coronaries. It's a very good option when there is a thrombus, but it is not for everybody. It has got its own special little niche place where laser is better than ordinary angiogram.
The next one is stents used today never fail because they are drug eluting releasing.
Another myth which patients ask is, will this stent last forever? Technology has become so much better, but there is no stent in the world which will never get blocked. So maybe 95% of our stents will do well, but it is not 100%. We are moving towards it, but we are not there yet.
What is the lifespan of a stent?
So we can't, it's like, if we put stents for 100 people, we can predict that 95 of them will do very well for about 10-15 years. In a small minority, about 5% of the patients, these stents can get blocked themselves. So the science is kind of decreasing the number, and we are identifying why it fails, why it doesn't fail, but we haven't got to that 100% target yet.
So the next one is, all interventional procedures are risk-free because they are minimally invasive.
Yeah, as the procedure becomes less invasive, the risk becomes less, but it never becomes zero. Even a small IV line, an IV drip has got its own risk. But when compared to an open heart surgeries, these procedures are less risky, but not zero. So we are not there where we can say like there's a zero risk to it. But for example, an angioplasty today will be 99.9% risk free, but not 100%.
This is also my favorite. Wearable cardiac devices can replace angiograph or interventional diagnostics.
No, wearable cardiac devices are devices which actually check on your rhythm. So they kind of check the electrical part of the heart, whereas your angiogram look at the plumbing aspects of the heart. So they are entirely different, and they are not the same.
So basically, I've heard my friends talking, like invest in a in a product, in a watch that can give you exactly what's happening in your with your heart. There are cases where watches have detected something is likely to happen, something.
Yeah, so the watches can detect the heart rate on a very high accuracy, especially the newer Apple watches, the Android watches can pick up heart rate abnormalities very fast, but those are electrical abnormalities. Unfortunately, the common disorders which we do get are plumbing disorders, which the watch can't detect. It can find out that the heart rate is becoming faster or slower, but it cannot pick up the abnormal. So it doesn't replace at all.
Okay, let's simplify this for people.
Yes.
Okay, let's simplify this for people. Yeah. You said plumbing disorders. What do you mean by plumbing disorder? What are the common discomforts that people get?
No, essentially,
or people tend to ignore.
So essentially, the common heart attack, or what causes people to kind of collapse when they're living a normal life, is usually a problem with the blood vessels. And these blood vessels are like actually small pipes which feed the heart. So they are like, the pipes which we have in the walls. And that occlusion is what produces heart attack. We also have wiring in the heart which can produce rhythm abnormals. So the smartwatches can only pick up the rhythm abnormalities. They cannot find out what is happening to the blood flow. So while a watch is very good to identify slow heart rate, fast heart rate, abnormal heart rate, it does not replace an ECG. It does not replace a visit to a cardiologist. I would put it this way. If you have a chest pain, you have to go to a doctor to take an ECG. You can't look at your smartwatch and find out that the heart rate is normal and reassure yourself.
This is also a myth which is very interesting, that through blood tests, you can identify heart attacks.
So over the last 10 years, 15 years, what has happened is we have identified an enzyme which gets released when the heart gets damaged. So what happens is heart is like an enzyme, like a muscle, and the muscle contains enzymes. So if we squeeze a lime, the lime juice comes out, and we can smell that lime smell for about 5 to 10 minutes. Likewise, when a heart gets damaged, we can identify an enzyme called troponin for about 5 to 10 days. And it's true. So today, the troponin's accuracy has become so much that within 2 to 3 hours after a heart attack, the troponin will become positive. So what has happened is there is a change in diagnosis. Earlier, if you have a heart attack, you have to do an ECG first. And if the ECG is normal, we would kind of get reassured. Today, world over, the transition is for the enzyme. If the troponin is negative and you have come after 3 hours, a troponin negative means you haven't had a heart attack in the last 5 to 10 days. So yes, that's actually a true fact. So there is an enzyme, but it is only valid for heart attack.
Okay.
It doesn't show that there is a block or not. It shows that the heart muscle is getting damaged or not.
Okay. So what are the other kinds of myths that you have heard? Like you must have seen a lot of patients, interacted with them. They would have said, "Sir, I was just thinking something like this and I was like normal." Like,
Yeah.
and I think there are any cases like that.
Yeah, I think the biggest myth which patients feel is, one is, if they are, like, for example, very healthy, run a marathon regularly, do their health checkups regularly. So they kind of get into a mode where they think that they are immune to heart disease. So they feel that everything is well. So I will not get a heart attack because my parents haven't got it. So unfortunately, there's an element of unpredictability which is there, even in a treadmill or some or test like that, which are about 90% accurate. So today, just because you don't have a risk factor doesn't kind of negate you. You do have to do your checks. And even if your test is normal, if you have a pain, you have to go to a cardiologist. The other myths which we see is, patients feel that diabetic patients are less risk, they don't have more chance. In fact, when you compare to a smoker and a diabetic patient has got much higher chance of developing a heart attack rather than a smoker. So these are the couple of things which.
And when patients come up with different theories, how do you respond to that? Because that could be the the most important factor of your interaction with them.
I think if you tell patients in a very, if we explain it to them that what they are thinking is wrong, then they are ready to accept it. If we point blank tell the patient that no, you're right and you're wrong and I'm right, ninga doctor, ana doctor. If you ask questions like that, then the patients are put off. I think that's so. I think we as doctors also have a role in educating them and telling them why they are, mistaken or misinterpreting the facts per se.
And tell me about the kind of awareness that is there. Like, though there are hundreds and thousands of doctors who are shattering, given opinions about what exactly it is. What is the kind of...
I think what happens is, one is the awareness is increasing, yes, but the patient would believe another patient the most. So even if the doctor says something, if a patient comes and says, நான் stent வச்சுட்டேன், ஒரு வருஷத்துல block ஆயிடுச்சு, then that's a very strong opinion about the stent which the patient will have. We have had patients who come and we say like, it's only one block, let's do an angioplasty, but they have a bad experience with maybe one of their relatives. So obviously, patient would listen to somebody whom he trusts more.
So my last question about myth.
Yeah.
AI and robotics increase procedure time and cost without real benefit.
So there is a steep learning curve when newer devices come in, including robotics. So what happens is, when the operator is using these devices for the first time, it does increases the cost, but it is going to be quickly changing in the future, where the robotics procedures will become faster and much safer.
Thank you so much for talking to us, doctor. For those who are not familiar with interventional cardiology, what does it involve and how different it is from the traditional methods?
Thank you.
Thank you so much.